Welcome everyone to the second vascular talk. This is on acute limb ischemia. My name is Utsav and I am a surgical and acute medical FY1, and I'm going to be talking to you guys today about, in brief, about the management of acute limb ischemia. So let's look at our learning objectives. We're going to briefly recall the arterial supply of the lower limb. We're going to define acute limb ischemia and identify the causes of it. We're going to describe the key characteristics of acute limb ischemia and the key principles involved in investigating it, and outline the clinical management of it. Let's briefly revise the arterial supply of the lower limbs then. The abdominal aorta splits into the common iliac arteries, and the common iliac arteries bifurcate at the pelvic brim into the internal iliac and external iliac arteries. The external iliac artery becomes the femoral artery as it passes below the inguinal ligament at the mid-inguinal point, halfway between the pubic symphysis and the anterior superior iliac spine. The femoral artery then has 4 branches in the thigh just below the inguinal ligament, before it descends and gives off a large branch known as the profunda femoris artery, and then itself passes into the adductor canal as the superficial femoral artery. The profunda femoris artery is the artery of the thigh and arises 4 centimeters distal to the inguinal ligament from the femoral artery, and its major branches are the perforating arteries and the medial and lateral femoral circumflex arteries. The superficial femoral artery then passes within the adductor canal and then becomes the popliteal artery that we can see here, which can be easily palpated at the level of the popliteal fossa. At the distal portion of the popliteal fossa, the popliteal artery then forms the bifurcation into the posterior tibial and the anterior tibial arteries. The anterior tibial artery passes into the anterior compartment of the leg, running on the interosseous membrane, as we can see here. At the level of the foot, it becomes the dorsalis pedis artery, which is palpable between the first and second metatarsals. The posterior tibial artery passes into the posterior compartment of the leg alongside tibialis posterior. It passes behind the medial malleolus, where it can be easily palpated, and divides in the foot into the medial and lateral plantar arteries. The peroneal artery is a branch of the posterior tibial artery which runs in the lateral compartment of the leg and is usually smaller than the anterior or posterior tibial arteries and is not usually palpable at the level of the ankle. Now let's look at the clinical importance of this with a case. 45-year-old man presents to A&E with an acutely painful right foot. He has a history of paroxysmal atrial fibrillation, and on examination, he's able to move his foot little because of discomfort, and you notice it's hard to palpate the dorsalis pedis and posterior tibial pulses. He has some loss of sensation in his toes. In comparison, the left foot appears well perfused and all the pulses on the left foot are palpable. There is no sensory or motor loss notable on the left foot. Which of the following would not be a suitable form of definitive management for this patient? Embolectomy, intra-arterial thrombolysis, angioplasty, amputation, bypass surgery. Again, make a note of this question and make a note of the answer that you think is correct, and we will run through the rest of the talk and come back to this question and the answer as well as an explanation for it. Acute limb ischemia. We can define acute limb ischemia, or ALI, as a sudden decrease in perfusion of a limb that threatens the viability of that limb. This sudden decrease in perfusion can be either complete or it can be partial, and this leads to rapid ischemia and poor outcomes if it is not treated within 6 hours. Hence, it is a surgical emergency. It affects 1.5 cases per 10,000 people per year, and it can manifest in a variety of forms. Most commonly, it is due to embolization and thrombosis in situ. So, embolization can be where there is a thrombus originating from a proximal source and it travels distally and occludes off an artery, for example, the superficial femoral artery or the profunda femoris artery, which then is accompanied by pain in the region supplied by that artery, so pain in the thigh, for example. The origin of the thrombus may be resulting from atrial fibrillation, for example in the left atrial appendage, or it may be because of a mural thrombus post-myocardial infarction, or it may be as a result of a prosthetic heart valve and poor INR control. Thrombosis in situ results when there is an atheromatous plaque within an artery which ruptures, and that thrombus forms and occludes that vessel. Compartment syndrome can occur as a result of trauma to a particular compartment in a particular limb. or acute limb ischemia can manifest as a result of a dissecting aneurysm or as a result of Raynaud's. The risk factors for acute limb ischemia are same as those for peripheral arterial disease, so smoking, hypertension, diabetes, mellitus, high cholesterol, and age over 60. And the presentation is the well-known 6 Ps of acute limb ischemia, so pain, pallor, pulselessness, paresthesia, the paresthesia being as a result of impingement of the blood supply to the nerves, the so-called vasa nervorum, perishingly cold, and paralysis. Paralysis being the most worrying of the symptoms, as it often ensues permanent loss of function. Referral to a vascular service may be as a result of acute pain or symptoms suggestive of peripheral arterial disease, so pain or intermittent claudication, or as a result of the patient having risk factors such as diabetes, non-healing wounds, or a need for compression hosiery. We can classify acute limb ischemia using the Rutherford classification here, which we can see there are 3 broad categories. First being viable, 2 being either marginally or imminently threatened, and 3 being irreversible, each being associated with worsening prognoses. It is also based on the sensory and motor deficit, as well as the audibility of an arterial or venous Doppler. And as we can see, you only hear both in a viable limb. You don't hear an arterial Doppler for all threatened or irreversibly damaged limbs, and you don't hear a venous Doppler unless there is irreversible damage to the limb. This will also form the basis of management plans for these patients as well, and so we will be revisiting this again shortly. So what investigations would we do for these patients? Initially, we would want to do routine blood tests and an ECG for all patients, and the blood test should include a lactate, hemoglobin, and coagulation and a thrombophilia screen, particularly for young patients, include a D-dimer and a group and save in case they need to be taken to theatre, and an ECG to show for cardiac causes as well. Imaging should be as per NICE guidelines, which recommend duplex ultrasound scan in the first instance for both limbs and consideration of contrast-enhanced magnetic resonance angiography. If that is not suitable, to then opt for CT angiography. And we can see here on the right-hand side of the screen a reconstructed 3D diagram of a CT angiogram taken from the Teach Me Surgery online website, where we can see complete occlusion of the right femoral artery over here. Acute limb ischemia is a surgical emergency and must be treated within 6 hours. It is very important to have senior involvement as soon as possible for these patients. Initially, all patients should be started on high-flow oxygen, have IV access, and continuous heparin infusion. Conservative management can be considered for patients who are Rutherford Classification 1 or 2A, so either a viable or a marginally threatened limb where there is no motor deficit, where you may consider a prolonged course of heparin with regular assessment of the APTT or the activated partial thromboplastin time. If there is no improvement, then we may consider moving on to surgical intervention. Surgical intervention is mandatory for those that are Rutherford Classification 2B and above, so immediately threatened or irreversible damage. When there is motor involvement, we want to consider surgical management. Surgical management can be in the form of either interventional management, which may be endovascular, where we are considering percutaneous catheter-directed thrombolytic therapy or percutaneous mechanical thrombus extraction, or it may be an open surgical approach, where there may be a thromboembolectomy, an endarterectomy, or a bypass surgery may be considered in these patients. Amputation should be considered if the limb is unsalvageable and there is a risk of damage or a systemic inflammatory response from revascularizing that limb. It is also important to be aware of long-term management in these patients as well. So patient education, encouraging the use of regular exercise, smoking cessation, weight loss, and also consideration of either a low-dose antiplatelet or a direct oral anticoagulant, or so-called DOAC. And it's also important to manage any underlying conditions such as uncontrolled atrial fibrillation, which may predispose to an embolus going on to cause the acute limb ischemia. And of course, rehabilitation programs with physio and occupational therapy involvement as well as part of the holistic management plan for these patients. As with any surgical management, there are always complications associated with it, and acute limb ischemia itself has a mortality rate of approximately 20%. An important complication of acute limb ischemia is reperfusion injury, where when we restore the perfusion to that limb, there is a sudden increase in permeability of the capillaries supplying that region, which may result in a compartment syndrome-like clinical picture. This is due to release of substances from muscle cells that have been damaged by the prolonged period of ischemia, and this causes a release of potassium ions, which may trigger hyperkalemia and arrhythmias associated with it, protons or hydrogen ions causing acidosis, as well as myoglobin, which may result in a renal form of acute kidney injury. Hence, it is very important that these patients are very closely monitored, rapidly treated, and if need be, made aware to intensive care for a possible need for a short course of hemofiltration or dialysis. So, going back to the single best answer question, which of the following would not be a suitable form of definitive management for this patient that we saw? A 45-year-old gentleman, embolectomy, intra-arterial thrombolysis, angioplasty, amputation or bypass surgery. The correct answer is D, amputation. As this patient has class 2B acute limb ischemia, there is amenability for interventional management at the moment. This patient has an immediately threatened lower limb. There is no current evidence to suggest that the limb is unsalvageable, as there is a clear, likely precipitating cause, which is the embolus secondary to the atrial fibrillation, which we can treat. And so amputation is not the correct answer in this case. So, in summary, acute limb ischemia commonly presents as acute limb pain and has many precipitating causes, commonly being embolization or thrombosis in situ. Duplex ultrasound scan of both limbs is suggested by NICE guidelines, followed by CT angiography if there is no possibility for a contrast-enhanced MRA. Both conservative and interventional options are considered, but it depends on the extent of damage and the suitability of limb salvaging in these cases. For more information, please visit many of these online resources such as BMJ Best Practice, Up to Date, and Teach Me Surgery, as well as looking up your local clinical guidelines and trust policies as well. Thank you very much. I look forward to seeing you all in the next surgical lecture, and please stay tuned to keep updated with the latest tutorials and the surgical talks. Thank you very much.